and good day. Thank you for joining the Asian Pediatric Pulmonology Society or APPS Grand Round. My name is Arunwan Pritipan. I am the president of APPS. We are very proud to have successfully organized 5 consecutive Grand Rounds online on the last Friday of every 2 months, and this is the 6th one. I would like to express our gratitude to the Hong Kong Society of Pediatric Respirology and Allergy for co-hosting this event. I truly appreciate all speakers' volunteer spirit that has made this grand round possible. I am pleased to introduce Dr. Daniel Ng, who will be the moderator today. Dr. Daniel Ng is a crucial figure in APPS, serving as the founding president. He currently holds the position of honorary consultant in pediatrics and is a specialist in pediatric respiratory medicine at the Hong Kong Sanatorium and Hospital. His dedication have been instrumental in the progress of APPS, gaining international recognition. I sincerely thank him for his time and effort in assisting and guiding every grand round since the first one. So please join me to welcoming Dr. Daniel Ng.
Thank you very much, Professor Arwan, for the very generous introduction. So my name is Daniel Ng. I'm your moderator tonight. So tonight we have an exciting program presented by Dr. Michelle Zhang, who is hailed from the Department of Pediatric and Adolescent Medicine in the United Christian Hospital in Hong Kong. So going to talk on 2 sisters with persistent wet cough, the solutions. And tonight we have a panel of three panelists. Who the first panelist is Professor Howard Tai Kampalapon from Mahidol University, Bangkok, Thailand. The second panelist is Professor Dong In Soo. He's from Seoul National University of Children's Hospital, Seoul, South Korea. And the third panelist is Dr. Ari Olivantil. He's from Jaya University, Indonesia. So without further ado, may I ask Michelle to present the 2 sisters. Michelle, please.
Good evening. I'm Dr. Michelle Zhang from the United Christian Hospital of Hong Kong. Today, I'm going to present the clinical histories of 2 sisters with persistent wet cough. So they are born in a Chinese family. This family has 3 daughters. The eldest one is healthy, while the younger 2 have chronic wet cough. Our index patient, the youngest one, is 7.5 years old. Born at full term by cesarean section with a birth weight of 2.88 kg. The birth process was smooth. Antenatal history was unremarkable. She suffered from perinatal pneumonia with right upper lobe and right middle lobe collapse at birth, requiring oxygen therapy, and was discharged on day 12 of life. On day 16, she was submitted for respiratory distress with chest X-ray again showing right upper lobe collapse. She was CPAP dependent for more than 6 months. A list of investigations was performed as shown here. Echo showed normal heart structure. Bronchoscopy on day 20 showed right upper lobe bronchostenosis. Diagnosis of gastroesophageal reflux with recurrent aspiration pneumonia was made based on the endoscopic finding of erythematous and edematous arytenoids and positive lipid-laden alveolar macrophages on the BAL. CT scan at 4 months old demonstrate right upper lobe collapse with focal narrowing at proximal right upper lobe bronchus, as well as right middle lobe collapse with distal tapering of right middle lobe bronchus. Ultrasound diaphragm noted paralysis of bilateral diaphragm. sorry. Her clinical causes was complicated with an episode of Haemophilus influenza pneumonia and bacteremia, and another episode of flu bronchiolitis with residual post-inflammatory wheeze, and Flixotide was prescribed as prophylaxis. She was finally weaned to room air and was discharged 8 months after admission. She then suffered from recurrent wheezing attacks from 20-month-old to 35-month-old, in which most of them were MPA negative and only partially responsive to Ventolin. She defaulted follow-up from 3 years old, claiming no major airway exacerbation, and coming back again with a major campaign of chronic wet cough and intermittent rhinitis symptoms at 4.5 years old. Sputum at that time grew commensals only. She was treated as protracted bacterial bronchitis with prolonged course of antibiotics, but the response was not satisfactory. Ultrasound during this period demonstrate improvement in diaphragmatic movement. Follow-up CT thorax again showed right upper lobe and right middle lobe atelectasis, with right upper lobe and right middle lobe bronchostenosis. There was no bronchiectasis or mosaic perfusion was seen. Bronchoscopy noted whitish thick sputum plug at right upper bronchus, as well as thick pale yellowish discharge in bilateral nasal cavity. BAL grew MSSA and varicella. Nasal cavity brushing electron microscopy unfortunately could not get adequate sample to make a confirmatory diagnosis of primary serious dyskinesia. So in view of the persistent wet cough, further investigations were done. Immunoglobulin pattern was unremarkable. Mantoux test was negative. Sweat test unfortunately could not get enough sweat for diagnosis. Azole nitrate oxide was inconclusive. Repeated nasal cilia electron microscopy was again inadequate for diagnosis. Nasal smear and sputum eosinophil were negative. Impulse oscillometry demonstrate normal airway resistance with positive bronchodilator response, possibly due to sputum retention. Subsequent spirometry revealed mild obstructive pattern with negative bronchodilator response. The girl is sensitized to house dust mites. There was mild thickening of maxillary sinuses shown on X-ray, while upper lobe collapse persists and as shown on follow-up chest X-ray. Echo showed no pulmonary hypertension. She was followed by our chest physiotherapist and was taught to perform regular aerobic exercise and nebulize hypertonic saline for sputum clearance. Regular sputum culture is saved. Flixotide prophylaxis was stopped in view of the spirometry results. She was put on intranasal steroid and normal saline nasal lavage for her rhinitis. Her family was referred to clinical genetic service for possible primary serious dyskinesia, and her vaccination status was optimized. She suffered from one episode of Haemophilus influenza and adenovirus pneumonia, and another episode of Haemophilus influenza related exacerbation half years ago, requiring antibiotics and hospitalization in the first episode. She was also found to have suspected high-frequency hearing loss over the left ear upon routine checkup and was referred to ENT surgeon for further assessment. Latest otoscopic exam showed no features of otitis media with effusion. The latest lung function tests show that she has mild obstructive pattern with positive bronchodilator response and normal total lung capacity. Tiotropium was added for bronchodilator effect. She could not master the technique of performing respiratory muscle strength measurement, and she was now asked to do regular peak flow rate measurement and asthma diary to document her symptoms at home. Her body weight and height are along 3rd centile, with weight for height along the 10th centile. She is pink in room air with no respiratory distress. Air entry is good with bilateral crepitation as well as wheeze on end expiration. inferior turbinates were mildly swollen with no features of OME noted on otoscopic exam. There was also no facial tenderness. She has no finger clubbing. Her development is normal. This was the chest X-ray on day 6 of life, showing right upper lobe collapse, which seems to be opened up on day 10. This video showed you the CT thorax done at 4 months old. So you can see the right upper lobe collapse and the right upper lobe bronchostenosis here, as well as the gradual tapping of the right middle lobe bronchus here. Chest X-ray at 8 months old again showed right upper lobe collapse. You can see it here. So follow-up CT thorax at 5 years old demonstrated similar findings. With right upper lobe and right middle lobe collapse, the right upper lobe bronchostenosis, as well as the tapering of the right middle lobe bronchus here. So I hope you can appreciate the mild thickening of the maxillary sinus on this sinus X-ray. So this is the latest chest X-ray, again showing you the right upper lobe atelectasis. So in summary, the younger sister has the following problems. 1, congenital diaphragmatic paresis. 2nd, persistent right upper lobe collapse. 3rd, recurrent VC attack. 4th, chronic wet cough. 5, intermittent rhinitis. 6, house dust mite allergy. And 7th, proportionate short stature. Currently, she still has persistent red cough, but the rhinitis system is much better controlled. I will then present the clinical history of the elder sister. She is 11.5 years old. Born at 36.6 weeks by cesarean section with a birth weight of 2.544 kilogram. Antenatal history was again unremarkable. She failed the newborn hearing test. She suffered from perinatal pneumonia with right upper lobe collapse at birth, requiring CPAP therapy for nearly 1 month and was discharged at 2 months of life. Again, a list of investigation was performed as shown here. Echo showed normal heart structure. Laryngeal cleft was not evident on feasible laryngoscopy. CT thorax on day 10 showed right upper lobe collapse with no obstructive mass or vascular compression. And just like her younger sister, she also suffered from recurrent VC attack. The most severe episode happened at 12 months old, which required intubation and also complicated with pneumothorax, requiring chest drain insertion. Bronchoscopy at that time found collapsed right upper lobe with whitish sputum puck. BAL was negative. Bilateral laryngotomy and Flomet insertion were done as thick mucoid discharge was seen in bilateral middle ear. Fixotype prophylaxis was prescribed and was off subsequently in view of relatively stable control. However, she suffered from chronic rhinosinusitis requiring regular intranasal steroid and normal saline nasal lavage, as well as persistent bilateral otitis media with effusion, with enlarged tonsils and adenoids, together with mild bilateral conductive hearing loss. And tonsillectomy and adenoidectomy was performed subsequently. She also has on and off red cough, but of less degree when compared to her younger sisters. Here show you the list of investigation done in the past 2 years. Chest X-ray show right upper lobe collapse, sinus X-ray reveal mucosal thickening at the left maxillary sinus. Follow-up CT scan demonstrate right upper lobe collapse, and also generalized bronchial wall thickening and inflammatory change of small airway in right upper and the right middle lobe. There was no bronchiectasis, no mosaic pattern. Retention and inflammatory changes in paranasal sinuses, middle ears, and mastoid were also noted. Immunoglobulin pattern was unremarkable. Mantoux test was again negative. Sweat test was normal. Nasal nitric oxide was low. Nasal ciliary brush electron microscopy was inadequate for diagnosis. Nasal smear and sputum eosinophil were negative. Total IgE was normal. Lung function tests demonstrate mild fixed obstructive pattern, normal FeNO, and normal lung volume with no gas trapping. Skin prick test was negative to aeroallergens. Echo showed no pulmonary hypertension. She was put on similar management plan as her younger sister. She suffered from 1 episode of influenza A pneumonia and 1 minor exacerbation in the past 1 year. Her maximum expiratory pressure is reduced, as you can see here, whereas the peacock flow is preserved. Her growth is along 25th centile. She is pink in room air with no respiratory distress. Chest is clear with good air entry. Inferior turbinate were mildly swollen. Features of OME were noted on otoscopic exam. No facial tenderness was noted. Her development is normal. So this was a chest X-ray on day 1 of life, showing right upper lobe collapse. CT thorax on day 10, and this is day 10. And this is 8 months old. You can appreciate the right upper lobe collapse consolidation. So this is the chest X-ray at 12 months old. Upon admission for the severe wheezing attack, you can also appreciate the right upper lobe collapse. So this is the chest X-ray. White upper lobe atelectasis with generalized bronchial wall thickening, clusters, retention, and inflammatory change of small airway in the right upper lobe, and also the right middle lobe can be seen on follow-up CT at 10 years old. So CT sinus demonstrate retention and inflammatory changes in the paranasal sinus, the middle ears, and mastoid. And this is the latest chest X-ray, showing that the right upper lobe collapse is improving here. So in summary, the elder sister has the following problems. First, persistent right upper lobe collapse. Second, bilateral persistent OME and conductive hearing loss. Third, chronic rhinosinusitis. Fourth, recurrent wheezing attack with fixed obstructive pattern shown on spirometry. And fifth, chronic wet cough. Currently, her lower tract and also rhinitis symptoms are rather well controlled. Okay, let's see what you think after listening to the clinical history of both sisters. What is the most likely diagnosis in the younger sister? A, the congenital diaphragmatic paresis. B, asthma. C, GERD. D. Primary immunodeficiency, E. Primary serial dyskinesia, F. Cystic fibrosis. You will have 20 seconds to choose your answer.
Okay, thank you, Michelle. The next panelist is Dr. Avi Olivanto from Indonesia. He's going to talk about the deferred diagnosis. Dr. Avi, please.
Okay, thank you. Thank you, Daniel, for your kind introduction, and thank you, Michelle, for your very clear and excellent presentation. So I think most of you just answer the E option that I think it was right. So I will discuss about the cause of the persistent wet cough on the younger sister. I will focus on the younger sister first. So if we look the baby in early infancy, so the patient had respiratory stress immediately after birth caused by perinatal pneumonia and right upper lobe collapse. She then hospitalized for 2 weeks in ACBU unit. So then she was discharged just to return several days later because of cyanosis during feeding. The examination show persistent right upper lobe collapse, and we can also see the milk expiration confirmed by lipid-laden macrophages and the possibility of GERD, which indicated by the reddening or edematous erythronate. So the patient then put on CPAP in PICU, and she was then CPAP dependent since then. So because the patient put on the long-term CPAP, and there was the difficulty to wean off the CPAP, so the ultrasound was performed, and diaphragm paralysis was noted. So I would like to highlight this problem first, as we know that in the absence of birth trauma and thorax surgery, I think it's less likely the patient had a permanent diaphragm paralysis. Then secondly, the use of prolonged CPAP can lead to disuse of diaphragm muscles and dysfunction of diaphragm. So the question raised is that truly paralysis or a temporary dysfunction? So if we look the examination using ultrasound, the paralysis would reveal complete immobility or paradoxical movement, while in dysfunction there should be reduced movement. But the severe diaphragm dysfunction can mimic paralysis, because maybe severe diaphragm dysfunction can show a very weak movement not detected by ultrasound. And the sign of the dysfunction may be the struggle to breathe effectively when CPAP is reduced. So I would not say that the patient has a really paralysis, but I would rather say that the patient has dysfunction, which is generally reversible, as we see in the patient with improve of diaphragm exclusion at the age of 3. Then the second possibility or second problem is the recurrent wheezing. As the persistent post-inflammatory wheeze occur in this patient and followed by recurrent episodes of wheezing, some may think that the cause of chronic wet cough is related to asthma. But actually, the persistent post-inflammatory wheeze would relate it to airway inflammation or mucus plaquing because there is poor sensitivity to bronchodilator treatment and montelukast. So I will say that the wheezing is more likely due to airway inflammation or mucus plaquing. And recurrent episode of wheezing later also non-responsive to salbutamol. So it may be due to viral-induced wheezing or bronchiolitis, and it also can be caused by structural airway abnormalities or inflammatory conditions. But the laboratory test, there is a skin prick test showed positive for house dust mites, but I think it's not clinically related to the wheezing because the nasal and sputum eosinophil was negative and total IgE level was normal. And VNO was failed to perform. I think that we can say that the asthma as the cause of chronic wet cough is less likely. It then proved by spirometry examination, which showed that obstructive lung pattern with bronchodilator reversibility test was negative. While in impulse oscillometry, there was a high resistance of small airway and also some positive relative reactivity of a small airway. So I would say that the wheezing is more likely due to viral-induced wheezing and may be caused also by a small airway disease. How about recurrent bacterial infection in this patient? Because the patient has chronic wet cough and recurrent bacterial infections, which partially responds to antibiotics. So maybe we can think about primary immunodeficiency. In this case, the patient had normal CBC and normal immunoglobulins. So I think that's enough to exclude the humoral immunodeficiency. And that's tell us that further examination about immunodeficiency was not necessary. Then if we delve deeper to the problem, the patient have chronic wet cough and recurrent respiratory symptoms, which mean that the patient have a chronic airway disease, and the chest X-ray show persistent right upper lung collapse, and also have chronic sinusitis. So it can be associated to recurrent or chronic infection and also chronic lung disease, which consistent to PCD. And the screening nasal nitric oxide show a low level of nitric oxide, but it is not low enough to conclude the PCD because in PCD usually very low. This inconclusive result actually does not rule out of PCD. And as we know, the PICADAR score will predict to patient with daily wet cough starting in early childhood whether they have PCD or not. In our patient, they have she had a score of 7, which is a very high likelihood of PCD. Then the result of the screening lead us to examine the electron microscopy. But unfortunately, the electron microscopy study only show scanty ciliated cells with hypoplasia of cilia, which show us there is a ciliary dysfunction. In the absence of the ultrastructure of cilia, it could not conclude that the PCD is the diagnosis. So the absence of significant numbers of ciliated cells may be caused by sampling issues and also may be caused by destruction of ciliated cells because of chronic infection or inflammation. So the option is to repeat nasal brushing to obtain better quality samples, or consider genetic testing for PCD-related gene mutations for definitive diagnosis. Prof. Su will tell in detail later. How about GERD? Because GERD can contribute to the chronic wet cough because the patient have BAL in 60 days old, have lipid-laden macrophage and erythematous erythemate, and there's presents recurrent right upper lobe collapse. So maybe we think about 24-hour pH monitoring or trial with PPI. Actually, in the patient, there is a lack of classic GERD symptoms such as regurgitation, heartburn, or feeding difficulties. So I will say that the GERD is less likely to contribute to the chronic wet cough in our patient. How about cystic fibrosis? Because the patient had a chronic wet cough and recurrent respiratory infection with right upper lobe collapse and chronic sinusitis found in X-ray. Maybe we think about repeat sweat test because in the previous test there is not enough sweat to collect, or CFTR genetic testing. So actually in the patient there is no symptoms of pancreatic insufficiency, for example, malabsorption or failure to thrive or greasy stools, but the patient have multiple episodes of Haemophilus influenzae pneumonia. In patient with CF, usually the infection is caused by Pseudomonas aeruginosa. So I think if we still think about CF to contribute to the chronic wet cough, we can repeat sweat test or CFTR genetic testing. But we should also see the what happened in the elder sister, as Michelle presented earlier. She had also chronic wet cough, recurrent episodes of bronchiolitis and viral-induced wheezing, and also have recurrent lobar collapse. So the pattern is similar to the younger sister. Then the lung function test show an obstructive pattern with some reversible obstruction, which may be related to mucus clearance rather than a bronchoconstriction. And she has also low FeNO and a negative allergy test. So the lung function is far from a characteristic of asthma, but may be related to airway problem, which may be caused by mucus clearance. She had also otitis media with effusion and conductive hearing loss, chronic rhinosinusitis, the Piquet score of 6 and nasal nitric oxide level was very low. And she has also a nasal ciliary brush electron microscopy findings, which inconclusive also. Actually, the patient has a strong clinical suspicion of PCD. So I will give a brief summary that in this case, a 7-year-old girl with history of chronic wet cough and recurrent respiratory infection is likely due to underlying airway clearance disorders such as primary ciliary dyskinesia. And in my opinion, genetics confirmation is required. She had multiple episodes of Haemophilus pneumonia and suspected of high frequency hearing loss, with the growth is slightly below average but remain active with good tolerance of exercise. And the point is her sibling present with a similar clinical pattern, including chronic wet cough, respiratory infection, and ear or hearing problem, and PCD suspicion. This similar presentation in both siblings will give us strong clinical suspicion of PCD, and definitive diagnosis using nasal ciliary brush in electron microscopy study is hindered by difficulty in obtaining adequate samples, and the disease chronicity itself likely to result in conclusive findings as well. And I would say that genetic testing should be prioritized for definitive diagnosis. But maybe Prof. Su will tell us more detail. And this is Paul to answer. How will you confirm the diagnosis of PCD? A, clinical with high Piquet, or B, chest X-ray with dextrocardia, C. Nasal and bronchial brushing for cilia transmission electron microscopy and motility study. D. Nasal nitric oxide. And E. Whole exon sequencing. Okay, I think enough. Yes, Prof. Sum will continue his part. Thank you very much.
Hello, I'm Dong In-seo. I'm most of members have chosen the C or E, and I will explain all of them and just see it again. Okay. Wait a second. Okay. Hello, I'm Dong In-seo from Seoul National University Hospital in South Korea. Today, I'll be talking about how we can diagnose PCD. I'll briefly introduce several methods of diagnosing PCD and then present a practical protocol for confirming the diagnosis. From a textbook perspective, diagnosing PCD is so intuitive that there is no issue with identifying it. As the name primary ciliary dyskinesia suggests, demonstrating dysfunctional ciliary movement in airway epithelium is a straightforward and effective way to diagnose the condition. By brushing deeper inside the nostrils, we can collect ciliated airway epithelium. Then, using high-speed video microscopy analysis, we can observe the pattern and frequency of cilia movement to determine whether it's dysfunctional. While in healthy individuals, you will see a rhythmic sweeping motion of normal cilia. In patients with PCD, the ciliary movement is unsynchronized and erratic. However, in the real world, diagnosing PCD isn't that straightforward. First of all, getting an adequate sample is tricky. Often, the scraped specimens don't contain epithelial cells, which makes the results inconclusive. Secondly, repeated respiratory infections can damage the epithelium, causing what's called epithelial denudation. In such cases, secondary denudation can't be distinguished from the absence of epithelial cilia due to ciliary agenesis. Thirdly, some patients refuse to cooperate with the brushing procedure. As many of you probably experienced during the COVID pandemic, inserting a probe deep inside the nostril is a nightmare, especially for children. This is why bronchial biopsies done during bronchoscopy, which cannot be repeated multiple times if the pathology report is inconclusive, pose a challenge. Finally, epithelial cell culture from an organoid can provide adequate cilia samples, but it's extremely costly and not practical for routine clinical use. Additionally, real-time assessment of ciliary movement isn't always possible. High-speed video microscopes aren't available everywhere. Moreover, during the fixation process, epithelial cells are no longer viable. As a result, we can only capture a snapshot of ciliary movement with scanning electron microscopy, or we can only observe ultrastructural abnormalities using transmission electron microscopy. In the figure on the right, we can see various types of structural loss in the normal 9+2 arrangement in patients with primary ciliary dyskinesia. Defects in the outer or inner D9 arms, as well as defects in the central complex, suggest that the ciliary motion might be impaired. However, recent reports have shown that dysfunctional cilia can sometimes appear to have a normal structure. Therefore, while positive results can confirm the diagnosis of PCD, negative results cannot fully rule out the disease. Alternatively, some experts assess ciliary function. A delay in saccharin transit time can be a typical sign of dysfunctional cilia. However, the outcome variables are so subjective that we can only suspect but not confirm or rule out a PCD diagnosis based on these test results. On the other hand, efforts to identify biomarkers have found that low nasal nitric oxide is a useful tool for distinguishing PCD patients from those suffering from other chronic respiratory conditions, such as cystic fibrosis or idiopathic bronchiectasis of unknown origin. Lastly, pathogenic variants in PCD-related genes are being explored as target markers for PCD. Recent studies have shown that functional abnormalities and ultrastructural defects can be linked to pathogenic variants in several PCD-related genes. The only challenge is that the database on PCD-related genes is still evolving and new genes are still being identified. Similarly, while positive results for pathogenic variants in non-PCD-related genes confirm the diagnosis, negative results do not completely rule out the possibility of PCD. Keep in mind, when it comes to the PCD diagnosis, false negativity, it means low negative predictive value, is the matter of concern. So what should we do? We should be aware that several methods are suggestive of PCD, but only a few tests can definitely confirm the diagnosis. First, obtaining samples of ciliated epithelium and detecting abnormal ciliary movements through high-speed video microscopy, or identifying ultrastructural abnormalities with transmission electron microscopy are reliable ways to diagnose PCD. Second, finding pathogenic variants in non-PCD-related genes in symptomatic suspected patients is another definite method of diagnosis. Although some reports regard low nasal NO as a definite marker, there is ongoing debate due to the possibility of both false positive and false negatives. Other methods are only suggestive and cannot confirm a PCD diagnosis. Indeed, only few centers around the world are capable of diagnosing PCD, which makes referrals from other clinics essential. For this reason, we designed predictive tools are definitely needed to identify which patients should be referred to specialized centers for PCD diagnosis. In this context, PICADA has been proposed as a practical tool for predicting primary ciliary dyskinesia by scoring responses to 7 questions about patients with a daily wet cough that started in early childhood. The predictive value of PCD is impressive for those with a PICADA score of 10 or higher. The 7 questions include: was the infant born full term? Were the chest symptoms in the neonatal period? Was the infant admitted to a neonatal unit? Does the patient have situs inversus or congenital heart defect? Is there persistent perennial rhinitis or chronic ear or hearing problems? If you encounter patients with these characteristics, please refer them to major centers equipped to diagnose primary ciliary dyskinesia. Many of you may be curious about the diagnostic sensitivity in a real-world setting. In a large center in South Korea, specialists shared valuable data from their experience. According to their report, 47 patients suspected of having PCD based on PICADA-related questions were evaluated with genetic testing. Of these, only 12 underwent biopsies, 8 from nasal and 4 from lung tissue. However, only 7 of these biopsies were successfully evaluated using TEM, and just 4 patients were confirmed to have PCD. This highlights the surprisingly low confirmation rate with TEM. In fact, only 17%, just 8 subjects, were ultimately diagnosed with PCD. Additionally, among the 37 patients who were not diagnosed with PCD, 5 cases were inconclusive, showing variants of unknown significance, I mean VUS, despite normal TEM findings. The 2 major academic societies have suggested practical approaches to confirming a PCD diagnosis with only minor differences. First, the ERS guidelines recommend nasal NO testing and high-speed video microscopy. If the results are negative and the patient's history isn't strong, it indicates PCD is highly unlikely. After that, analyzing ciliated epithelium, either through TEM or repeated high-speed video microscopic analysis, is highly recommended, as positive results can confirm the diagnosis. If results are inconclusive, genetic testing is suggested as an alternative. In contrast, the American Thoracic Society recommends nasal NO testing first for those over 5 years old, but only using a specific type of device. If nasal NO levels are low and cystic fibrosis is excluded, it's considered definitive for PCD diagnosis. In cases where results are normal, but clinical suspicion remains, genetic testing is recommended. If nasal NO testing isn't available, genetic testing is done first, followed by biopsy if no definite genetic defects are found. I believe both guidelines are practical, so each center can choose whichever option fits their resources best. This is the last slide. Please keep in mind that ciliary biopsy or genetic testing in clinically suspicious patients is only confirmative when positive. However, negative results do not rule out PCD. Therefore, continue to suspect PCD and consider reassessing with biopsy and genetic testing until a definite diagnosis is made. Let's get back to the poll. High picada is only suspected. Dextrocardia is also suspected. TEM or HSVMA is definitely confirmative. Low nasal NO rather than higher one is more suspected. Finally, pathogenic variants rather than VUS are more suspected. Thus, the option C is correct. Thank you. Let's move on to the poll 3. How are you going to manage the 2 sisters? A, prophylactic antibiotics. B, antibiotics on exacerbation. 3, GROMMED insertion. D, bronchodilator. E, inhaled steroid. F, chest physiotherapy. G, regular sputum culture. H, annual flu vaccination. I, nutritional support. J, intranasal steroid. Okay, chest physiotherapy is the most frequent, most selected option. I think let's move on to the next speaker. Thank you.
Okay, thanks, Dr. Dong. So my name is Harutai Kamalaporn. I'm come from Mahidol University, and thanks to the APPS organization that inviting me to share my experience about management of PCD. So the PCD was first described years ago, and as you may see, it's comparing to the cystic fibrosis. PCD is kind of orphanage disease because most of the funding goes to cystic fibrosis, but you can see that the first published multi-center RCT for PCD is just like maybe when the 2020, and the second one is 2023. So I will share the knowledge from the state-of-the-art review and the Kendick textbook, as well as some study. Okay, so contrary to the past belief, the PCD is not a mild disease because 38 to almost half of the patients of adult with PCD was suffer from the oxygen deficiency, so they would need the supplementation of oxygen plus the severe pulmonary dysfunction, as you may see from our two sisters in our two patients like this, that the FEV1 is depletion at some point, and some of them may need the lung transplantation in the future. So the treating and managing the primary ciliary dyskinesia is about the goals, is about the improving the lung function by doing the airway clearance and limiting the disease progression using antibiotics and prevents the respiratory tract infection, no matter what the lung infection, the sinusitis, or the otitis media with effusion. So there comes about the advantage of the vaccines. So I like this picture very much. This is from the PCD Foundation, which is they have some interesting issue in there for the patient, the caregiver, for the healthcare provider. And let's see the picture. I like this t-shirt very much because they say everything clear the way for me. That means airway clearance is the best way for treating the patient. So this is from the Pediatric Pulmonology 2016, when they published about the PCD Foundation consensus recommendation based on the state-of-the-art review. So they recommend about the area clearance and the vaccine. By that time, it was influenza, pneumococcal vaccine, the RSV prevention, and antibiotics for 2 to 3 weeks times, longer than the usual pneumonia or longer than the sinusitis or otitis media itself. So the antibiotics, including the amoxiclavulinate, cephalosporin, and inhaled aminoglycoside if Pseudomonas aeruginosa present. By that time, the bronchodilator, hyperosmolar agent, and Dornase alpha is still controversy. They recommend about the spirometry 2 to 4 times a year, plus the surveillance, the sputum culture, to see which germs is the colonized. But 3 years later, for 2019, in the Kendick, the most updated in the Kendick's textbook, they mentioned about almost the same thing, but the vaccines, they mentioned about pertussis and actually measles as well for the PCD patient. And antibiotics based on the sputum gram stain and cultures. They recommend that bronchodilator may aid the mucus clearance in the patients who have airway hyperreactivity. So at some point in the patients that Dr. Michelle presented, I think the bronchodilator may be useful as well. An anti-inflammatory agent, the deoxyribonuclease and hypertonic saline was recommended, but they recommend about 7% of our saline for the nasal irrigation. And measure and facilitate airway clearance may be beneficial. However, they still have the specific indication and utility in PCD have not been yet defined. So you have to choose from or the tailor-made from patients to patients. And the prophylaxis with nirsevimab is now recommended against RSV in all infants with PCD for their first RSV season. In Kendick textbook, they mentioned about the patient and family counseling, which is very important, and avoid the smoke, pollution, and respiratory pathogens, and the lung transplantation if the chronic respiratory failure occur. So for Pseudomonas eradication, they mentioned about tobramycin inhalation twice daily for 20 days on, 20 days off. And still, if the positive sputum culture, maybe use the IV ceftazidime and tobramycin for another 2 weeks time, followed by inhalation of tobramycin. So the common pathogen in PCD is as shown, and they mentioned about low dose azithromycin may help in reduced exacerbation in the Frontier Pediatrics 2023. And for efficacy and after azithromycin, it has been shown in the Best-Cellier multi-center RCT study. So people with PCD may benefit from the treatment with thrice weekly, maybe like at my institution, we give it like Monday, Wednesday, Friday, something like that. Yeah, for azithromycin, and they can decrease pulmonary exacerbation rates without apparent increase in antibiotic resistance. So most of the PCD treatment actually imitate the cystic fibrosis regimen. And another one for the PCD itself called the Clean PCD RCT and published in Lancet this year. So the multi-center international one was conducted, and it has been shown that there is no improvement with inhaled hypertonic saline alone. It should be combined, the hypertonic saline, with the selective epithelium sodium or ENaC. The name is idursulfide. I am not familiar with this, but that is something new in the RCT going on. And with the orthotis media with effusion or OME, we recommend the myrinectomy plus or minus adenoid tonsil and adenoidectomy, because adenoid hyperplasia can cause the obstruction of the mucus clearance. So adenoidectomy may be benefit for the patient with the PCD as well as the chronic sinusitis. And antimicrobial agent plus the decongestant. And what about the grommet for irritated media? The grommet is the ventilation tubes in the plastic silicone one like this. Put it in inside to drain the secretion and the effusion from the middle ear. So the indication, because the fluid collection of the middle ear can cause a hearing impairment, which you can appreciate in two patients that Dr. Michelle presented, and it can cause a speech problem as well, and plus the decrease the school performance because the children cannot hear the teacher, so maybe the school performance is decreased because of the hearing problem as well. So and the sinusitis itself, we recommend to do the nasal saline irrigation and the antibiotics against the common germs. And one of our patients has the Moraxella catarrhalis. I believe the first patient has a sinusitis, and the BAL revealed the Moraxella catarrhalis plus MSSA. So you can choose antibiotics to cover the germs that you can find. And intranasal steroid, and I would like to emphasize that you have to avoid antihistamine because it can make the secretion become thicker. And the surgery for polyp removal and adenotonsillectomy is recommended. For the patient with chronic rhinosinusitis, which is persistent, maybe we can do the functional endoscopic sinus surgery in the severe case. And this is my daughter who is demonstrating the nasal saline wash, because sometimes it can be like very difficult for kids and they may like refuse to do it. So usually the trick is to put it in and ask the child to do it by themselves, because they cannot. Yeah, and say when you put the saline in, so it won't suffocated or won't feel like very painful or aspirate the saline. Okay, yeah, that was when she was 4 years old. Okay, so this is the phase. And sometimes with the PCD, the patient may have polyps which clog or obstruct the nasal passage and the mucus secretion as well. So the surgery to remove the polyps and the sinus surgery may be recommended. And with the bronchiectasis, you might do the postural drainage and aerosol therapy plus area clearance therapy with you may use the ultrasonic nebulization, hypertonic saline. In Thailand, we use 3%, but in North America, they recommend 7% right now. Yeah, hypertonic saline has been shown to improve the lung function as well. And we can use it with the Acapella, which is the vibrating PEP. You can put on the nebulization at the same time because it takes time to do the airway clearance, and kids might feel like they don't want to do it quite long. Cough is an effective clearance mechanism. You have to ask them to do the huffing, and this is the patient doing the huffing. And after that, after the huffing, they can cough off the mucus. Yeah, and this is the secretion maybe come off after the effective cough. Okay, so the surgical intervention may include the tympanostomy, the FES, and lobectomy in the rare case. In the case with the persistent localized bronchiectasis, it may cause. Yeah. So what should be monitored? You should monitor about the growth and nutritional status because adequate or optimum BMI reflects that you have a good care for the patient, and the lung function test, oxygen saturation, sputum culture, and sensitivity test. You have to do the chest X-ray surveillance every 2 to 3 years or more often if clinical indicated. Hearing test is essential to avoid a speech and educational problem. And you have to monitor about the stress and anxiety of the caregiver because this is the mental health challenge for the chronic disease because it is a burden of care and kids have to do this for their long life. Is very, very stressful for the parents as well to force the kids to do their airway clearance every single days. And at the school, in the PCD Foundation, I love it. They have their template of the school letter that because kids cough every day and we encourage them to cough because they have to remove that secretion. You have to mention that it is essential for them to have the product cough, but it's rarely contagious because kids may have the school bullying because they cough a lot and almost every day. And this is the last slide because right now we don't have the specific treatment for the PCD yet, but there are some study going on to try to modify the gene to restore the normal celiac mortality in the PCD. Yeah, we call the transcriptase activator-like effector nuclease or TALENs, but unfortunately, it's not really promising right now. The successful rate is very low right now. Yeah, but still, something's going on, so we have to hopeful for that. Okay, I would like to stop now. Thank you.
Thank you, Professor Howard Thai. I want to thank all the 3 panelists, Dr. Ari, Professor Su, and Professor Howard Thai for excellent discussion about the approach to children with persistent wet cough. I hope that you all find the solution to figure out how to diagnose the true pathology. And then we can also learn from Professor Su about the confirming the PCD diagnosis. And find, of course, for Prof. Howard Thai to share with us the information about how to manage a very difficult case of PCD. So I hope all of you would join me to thank the presenter, Dr. Michelle Jiang, and the 3 panelists. Thank you very much. And I would like to also pass over the mic to Professor Ann Goh, who is the immediate past president of APPS, for a concluding remark. Prof. Ann, please.
Thank you, Daniel, and thank you to all the panelists as well as the presenters and moderator for doing such a good job at presenting and approaching this case of the two sisters with PCD. I'd like to ask all of you attending to please set these dates aside because we have got our APPS annual meeting that will be held in Oman this year on the 13th to the 15th of December. So do consider attending this, block off those dates, and we hope to see you there. Moving on as well, we also block off these dates next year, which is the 1st to the 4th of April, because that will be our next year's annual congress, and that will be held in Bangkok in Thailand. And we again also look forward to seeing you there with us. Last of all, do block off the dates for our next Grand Round meeting, which will be in 2 months' time in the last Friday of November. That should be the 29th of November. And we hope to see most of you coming back to join us again on that day. Do give us your feedback. This is an evaluation form. Just scan it so that you can fill up the feedback form and give us your feedback so that you can help us improve how we can do this better. So we just thank you again for attending this Grand Rounds, and it was good to see that many of you were present today. Thank you, everyone.
أهلا بكم في سلطنة عمان.
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 أهلا بكم في سلطنة عمان.